Hi. The purpose of this lecture is to take a close look at glucose metabolism and especially looking at type 1 and type 2 diabetes. So we're going to differentiate between the etiologies of type 1 and type 2. It's important that you know the difference between the two. We'll look at the acute complications of diabetes as well as the multi-system effects of diabetes and hypoglycemia. And then we'll end with talking about some of the changes in endocrine function as we get older. The pediatric stuff is pretty much integrated throughout. So when we think about diabetes mellitus, we're thinking about defective insulin secretion and or utilization of insulin. It really is a group of metabolic disease. It isn't just one thing, but all of these types of diabetes are characterized by either not enough insulin being secreted or the insulin not being appropriately utilized. So with type 1 and type 2, we probably have a little bit more understanding of those two. We're going to talk about those specifically. With gestational diabetes, this is glucose intolerance during the pregnancy. Now, what usually happens in a gestational diabetes is after the mom delivers, she returns to normal, unaffected glucose metabolism. However, we do know that women who experience gestational diabetes should be monitored throughout their lives for the appearance of type 2 diabetes. With steroid-induced diabetes, that's actually a result of long-term steroid use. What can happen in some of these patients is you can actually see once they get off the steroids, their glucose metabolism turns to normal or back to a normal glucose metabolism pattern, and then if they have to go back on steroids, then they may have hyperglycemia again. When we think about how we diagnose diabetes, we have these three major criteria from the American Diabetes Association as well as the American College of Endocrinology. Increasingly, we're using the hemoglobin A1C, not only in our monitoring efforts, but also in our diagnostic efforts. Remember, A1C looks at a longer-term glucose level, percentage of glucose in the red cell, as opposed to getting a serum level. An elevated fasting blood glucose as well as an elevated glucose 2 hours after a meal is also used in our diagnosis. Let's talk first about type 1 diabetes, but even before we talk about type 1 diabetes, let's talk about insulin and let's talk about glucose metabolism. We know that beta cells from the pancreas, the beta cells release insulin and amylin, and their overall purpose is to decrease glucose. Alpha cells, also in the pancreas, release glucagon. The purpose of glucagon is to increase the glucose level. So what do we need insulin, amylin, and glucagon for? And I go through this, and I know this is normal physiology, but if we don't have this in our heads, it's kind of hard to remember the rest of it. So with insulin, we know that insulin stimulates the skeletal muscles to take up glucose as well as convert that glucose to glycogen, which is our storage form of glucose. It prevents glucogenesis by the liver by inhibiting enzymes. It prevents the breakdown of glycogen, and at the same time it stimulates adipose or fat cells to take up glucose. Last but not least, it's important that we remember that insulin decreases the appetite center in the hypothalamus. We know that our insulin receptors are on the plasma membranes of our cells. Amylin, which also comes from the beta cells, inhibits the secretion of glucagon. It slows gastric emptying and it helps us feel full, increases satiety. So then what do those alpha cells do? Well, they release the glucagon. Glucagon stimulates the liver to convert glycogen to glucose, to convert our storage form into a usable form. So as a result then, insulin and amylin should suppress glucagon. So the beta cells, if they're working well, should suppress the alpha cells as far as glucose metabolism. So what happens in type 1 diabetes, and what is that? Well, we know that in type 1 diabetes, the characteristic of this pathology is the loss of beta cells and therefore the production of insulin. There are two forms. There's a non-autoimmune, or a 1B, as well as an autoimmune, which is type 1A. Type 1A is the most common, so that's the one we'll talk about. With the autoimmune form of type 1 diabetes, type 1A, we have pretty good information that there is a genetic susceptibility, probably on one of the HLA genes, as well as suspected environmental factors. What we see is that in this autoimmune type 1 diabetes, the more common type, we have dysfunction of both the alpha as well as the beta cells. So what happens then is we have excess glucagon being produced by the alpha cells, resulting in hyperglycemia and elevated ketone levels, hyperketonemia. When we look at the beta cells, we are primarily concerned with immune-related T-cell mediated beta cell destruction. So this is where the immune system again comes into play. What happens with that immune-related T-cell destruction is that lymphocytes and macrophages infiltrate the islet cells. Islet cells of the pancreas are where you have your beta cells. As a result, there is also an autoantibody being produced against the islet cells, against insulin, and against GAD, or glutamic acid decarboxylase. GAD, or glutamic acid decarboxylase, is an enzyme in the beta cells that helps coordinate the release of insulin. So when we lose that, we lose the ability of our coordination. There's also a suggestion that there may be a role in the beta cell destruction of the T regulatory cells being inactivated. The other piece that has also been implicated in this autoimmune etiology is whether or not part of the autoimmune etiology may be in a response to a virus that also caused some damage. So how is that different than from type 2 diabetes? Well, with type 2 diabetes, we also suspect that there is a genetic as well as environmental interaction. On the genetic side, we are looking for genes that are related to the beta cell mass as well as function of the insulin receptors themselves. With the environmental interaction, we know that there is a very large environmental interaction related to age. As we get older, the incidence of type 2 diabetes definitely goes up, especially after the age of 65. With obesity, with hypertension, with inactivity, as well as that idea of family history. We also know that type 2 diabetes is part of the metabolic syndrome. Metabolic syndrome increases the risk of developing type 2 diabetes, or it may be a part of the syndrome itself. And this metabolic syndrome occurs at all ages and all genders. Metabolic syndrome is characterized by an increase in the waist circumference, elevated triglyceride levels, decreased high-density lipoprotein cholesterol, hypertension, and hyperglycemia. So that's that metabolic syndrome. And remember, the phenotype of the metabolic metabolic syndrome, with the increased waist circumference was the apple-shaped individual. And remember that adipose tissue in the waist in this metabolic syndrome is more metabolically active than the peripheral fat cells that you'll see in someone who is pear-shaped. One thing that has recently come to light is the issue of obesity. Now, not that we haven't suspected for a long time that individuals who have an elevated BMI are more likely to develop diabetes. But what is interesting is there's been more interest in looking at different races. In general, when we think about obesity, we think about a body mass index greater than 25. What we found is that 20% of individuals who are of Asian descent have both diabetes as well as hypertension, and their BMI has not been that high. The incidence of diabetes and also hypertension, but especially the diabetes, has been associated with a body mass index of 23 or greater. So what they've done in the American Diabetes Association is actually change the diagnostic guidelines to identify that a BMI of 23 in someone of Asian descent is significant because they have a higher percentage of body fat at a lower BMI than other racial groups. So what are the keys of type 2 diabetes? When we think about type 2 diabetes, there are two significant keys, and these are important: insulin resistance and decreased insulin secretion by the beta cells. Insulin resistance is the most important thing that we want to remember. And then also identifying what's going on with insulin secretion by those beta cells. What happens in insulin resistance is insulin-sensitive tissues fail to respond to the circulating insulin. They are resistant to the insulin. This has been related to a number of different things that are happening with that insulin. So this has been related to molecule abnormalities of the insulin itself, to insulin antagonists, to insulin receptors being downregulated. Remember that high levels of hormone actually decreases the number of receptors. It's been associated with altered glucose transporter proteins, as well as decreased activation in the post-receptor kinases. The other thing that happens within type 2 diabetes is that the alpha cells actually become less responsive to insulin. As a result of the alpha cells being less responsive, therefore not inhibiting hyperglycemia, there is an increase in gluconeogenesis. So it's important to have that pathology straight. So what about that role of obesity in insulin resistance? We know that what happens in obesity is we lose the modulation of the adipokinins by the PPAR system. And remember that PPAR system is supposed to increase leptin in resistance and then decrease the adiponectin. In addition, in insulin resistance, there are elevated levels of free fatty acids that then lead to intracellular deposits of triglycerides, and the lipids interfere with insulin signals inside the cell, as well as decrease the response of the tissue to the insulin themselves. This then leads to an alteration in both incretin as well as glucagon secretion, ending up in an increase in inflammation. As we have that release of the inflammatory cytokines we have the release of inflammatory cytokines from the adipocytes. We, at the same time, with the obesity and insulin resistant, oxidative phosphorylation is altered in that mitochondria, so we're not doing as good a job with energy metabolism. And with obesity and insulin resistance, you will see an elevated level of insulin and a decrease in the insulin receptors. And so what they've actually been able to do then is they've been able to predict which individuals who are obese may actually develop type 2 diabetes by measuring an inflammatory marker called T17. It has been strongly associated with type 2 diabetes in individuals who are obese. However, while it is associational, we have not identified causative or an absolute correlation at this. Although it's correlated, we can't go to causation, but there's a lot of interest in the inflammatory side of obesity and insulin resistance, therefore type 2 diabetes. Let's talk about the other things that are happening in type 2 diabetes with this insulin, with the hyperglycemia. We know that there is a decreased cell mass leading to beta cell dysfunction. Because of the beta cell dysfunction, there is more hyperglycemia and free fatty acid collection. This then results in cellular apoptosis. The inflammatory cytokines are toxic, and we also believe there is a role of autoimmune destruction that also causes a decrease in the cell mass and those beta cells to not work as well. Last but not least, leptin is present, and it decreases the insulin synthesis. With the glucagon pathway, as mentioned previously, the alpha cells become less sensitive to insulin inhibition. Therefore, there is more glucagon being secreted. Now remember, glucagon normally is inhibited by hyperglycemia and is secreted when the blood sugar drops, goes to the liver, undergoes glycogenolysis and gluconeogenesis. With amylin, there is a decrease in the amylin. Amylin, remember, is the second hormone that comes from the beta cells, and we need that amylin to affect satiety. It is normally secreted with insulin, and the idea of the amylin is to delay the nutrient uptake and suppress the glucagon after meals. Therefore, it becomes an anti-hyperglycemic. The last two hormones that are groups of hormones that are important are the incretins, which is the GLP-1 and GIP. In type 2 diabetes, these are not present to increase the insulin response to meals. And in ghrelin, there are much, much lower levels of ghrelin, therefore higher levels of insulin and leptin, again leading to insulin resistance. So with all of that happening then, what's the end result of what happens in diabetes? We're going to look at acute complications of diabetes as well as chronic complications of diabetes. And again, this plays whether this is type 1 or type 2. We talked about gestational and steroid-induced, but remember those are generally episodic as opposed to ongoing for many, many years the way type 1 and type 2 are. Probably the most commonly known acute complication of diabetes is ketoacidosis. In ketoacidosis, there is a lack of insulin and an increase in the counterregulatory hormones. Those counterregulatory hormones that are there to increase more insulin include cortisol, glucagon, growth hormone, and catecholamines, because remember those are being elevated, so cortisol, glucagon, growth hormones, and the catecholamines are all going to, the net effect would all be to increase the blood glucose level, just as insufficient insulin would also increase the blood glucose level. So as a result then you have an increase in glucose production as well as a decrease in the tissue use of the glucose. With that decrease in glucose uptake, there are more fats being mobilized. There is more gluconeogenesis by the liver, and that also then leads to the development of ketones, or the genesis of ketones by the liver. When those liver pathways are activated, glucose and ketones become actually glucose and ketone forming. The liver overproduces the acids, especially the ketones, and the bicarbonate buffering begins to fail. As a result, then, there is what kind of acidosis? Yes, it's an anion gap acidosis. Very good, because of the ketonemia. At the same time, because this is acidotic, you will see an intracellular hypokalemia. Now, ketoacidosis frequently manifests as the 3 polys, and that's what you'll see with a ketoacidosis. You have polyuria, polydipsia, and polyphagia. So when you think about polyuria, remember that there is a huge amount of glucose being produced. You have overwhelmed the renal threshold, and because you've overwhelmed the renal threshold with the hyperglycemia, it serves as an osmotic drag, therefore polyuria, taking fluid with it. Polydipsia, well, that makes sense. You're getting rid of a lot of fluid. The cells are being dehydrated. Therefore, the individual becomes volume depleted, and they're thirsty. And then polyphagia, because without insulin, remember, there's not enough insulin here. Insulin unlocks the cell or allows cell to cross that cell's membrane. So the cells are starving because they don't have insulin to let the carbohydrates into the cell for energy, therefore stimulates hunger. Now, ketoacidosis is much more likely in type 1 diabetes as opposed to type 2 diabetes. And this is because in type 1 diabetes, insulin is absent. Remember, the beta cells were destroyed. In type 2 diabetes, you have insulin sensitivity, or you have decreased production of insulin, but you still have insulin there. That's why type 1 diabetes is more likely, someone with type 1 diabetes is much more likely to develop ketoacidosis. Because the type 2 diabetic still has insulin, therefore that essentially avoids that ketone production by the liver pathway. The other acute complication in diabetes that's important is hyperosmolar hyperglycemic syndrome. This is what you'll see in type 2 diabetes more commonly. In this, the insulin deficiency is less than in diabetic ketoacidosis, but the volume deficit is greater. Again, the insulin levels are sufficient so that ketosis does not develop, but they have very, very high serum glucose levels. So this is the adult with type 2 diabetes that would come with a blood glucose level of 7, 8, 900, even into the low 1000s. Significant volume derangements, significant electrolyte dysfunction, but they do still have insulin on board, therefore are not ketotic, and that's why they call it hyperosmolar hyperglycemic syndrome. Don't usually see it in type 1. Now, let's step away from hyperglycemia for a minute on the acute side, because these are both acute, and let's look at acute hypoglycemia. Hypoglycemia is potentially deadly because the brain needs glucose. Brain cells do not store glucose. And they have both challenges and dangers in elders as well as in children. The biggest challenge in an elder is hypoglycemic unawareness. This is especially likely to happen after the age of 75. And we started noticing this because we identified that individuals over the age of 75 in hospitals had a higher mortality related to hypoglycemic episodes. So why does this happen? Well, as we age, our nervous system response to hypoglycemia, which is the release of epinephrine and stress hormones, is decreased. As a result, then, we don't have the physical symptoms that indicate that the blood sugar has dropped. We also identified that the hypoglycemic lack of hypoglycemic awareness is more likely to occur in someone who has had diabetes for a long time or who has had frequent hypoglycemic episodes. Last but not least, when we think about elders, is we have to think about the aging effects on our liver as well as on our kidneys. We know that many of the pharmaceuticals that we give have to be metabolized by the liver and excreted by the kidneys. So the pharmacokinetics of medications that can have the side effect of hypoglycemia become more likely as we get older. So what about with children? Well, with children, one of the things that has been identified is that brain activity after the blood sugar has normalized does not return to to normal very quickly. There was the whole thing got kicked off several years ago by a small study of 20 patients between the ages of 12 to 18. 10 of the adolescents were hypoglycemic, 10 were hyperglycemic. In both of these populations, both hypoglycemia and hyperglycemia, brain activity did not return to normal after the blood sugar itself normalized. There was a delay. So how does hypoglycemia generally manifest? Generally, it manifests as headache, dizziness, confusion, weakness, decreased mental acuity. And it can also be a cause of seizure. Those of you that work in an emergency department may recall that when someone comes in with new onset seizure, one of the first things you do is check a blood glucose level, because remember, brain cells don't store glucose. They need a steady supply. Let's turn our attention then to the chronic complications of diabetes. There are 4 major pathways in the chronic complications: oxidative stress, the polyol pathway, protein kinase C, and glycation. In oxidative stress, we've talked about this before, but there is an increase in the reactive oxygen species. We know that when there is an increase in the reactive oxygen species, this stimulates the pro-inflammatory cytokines and causes end-stage down the stream tissue and cell damage. In the polyol pathway, this is an alternate pathway for glucose metabolism, but it's especially used for tissues that don't need insulin for glucose transport. So this is the kidneys, the red cells, the vessels, and the peripheral nerves. When this polyol pathway becomes overactivated by persistent hyperglycemia, there's an accumulation of sorbitol. When sorbitol increases within the cell, that then increases the intracellular osmotic pressure. At the same time, there is also less glutathione. Glutathione is an antioxidant. So without that glutathione in the polyol pathway, oxidative injury in the blood vessel cells occurs. The third pathway is the protein kinase C pathway. Protein kinase C is activated by an elevated blood glucose level, and protein kinase C is an intracellular signaling protein. When it is activated, it increases insulin resistance, the production of cytokines, and angiogenesis. As a result, then, this activation of protein kinase C leads to microvascular complications. And last but not least is glycation. In glycation, the glucose binds irreversibly to collagen, proteins in the red cells, the vessel walls, and the interstitium. Now, this is important because binding should be reversible, not irreversible. So when the glucose makes these irreversible binds, there are advanced glycation end products which cause tissue injury. And this tissue injury occurs via abnormal cell proliferation, through inducing inflammation, and also by leading to procoagulant changes in the epithelium due to platelet adhesion and an increase in platelet adhesion and a decrease in fibrinolysis. So I would encourage you, don't you like it when I hint? Oh geez. So have a good sense of these complications, because again, whether this is type 1 or type 2, these are the pathophysiologic mechanisms or pathways in which the chronic complications of diabetes mellitus occur. Oxidative stress through the reactive oxygen species, that alternate pathway for glucose metabolism, the polyol pathway that leads to intracellular osmotic pressure, as well as oxidative injury, activation of protein kinase C, which is a signaling protein that increases insulin resistance, and angiogenesis, which causes some of those microvascular complications. And then with the glycation, this irreversible binding that then leads to the advanced glycation products that ends in abnormal cell proliferation, inflammation, and procoagulant changes in the endothelium. What then does this actually look like? Well, the three bigs are microvascular disease, macrovascular disease, and neuropathy. The two most common and troubling sites of the microvascular disease are in the retinas as well as in the kidneys. Now, we already talked about what happens in the kidneys, so let's talk about the retinas. With this microvascular disease, and remember you've got that protein kinase C and the glycation end products, these lead to hypoxemia and damage to those very, very small vessels of the retina. This leads to vasoconstriction, platelet aggregation, and angiogenesis. What happens in this retinopathy, because this does occur over time, now remember, chronic complications are most commonly associated with persistent hyperglycemia, although genetics may also play a role. But individuals tend to lose their vision in stages. It starts with a non-proliferative stage, and we can see this when we check the back of the eye and we check the vessels. That then leads to a pre-proliferative stage, and the final stage is a proliferative stage. And in that proliferative stage, this is where you're seeing a lot of the platelet aggregation and the angiogenesis. When we think of macrovascular disease, one of the biggest things we're thinking about is the acceleration of the atherosclerosis. Remember, we talked about the fact that hyperglycemia is pro-inflammatory. Go back to your pathways. As a result, then, individuals with diabetes have a higher incidence of both coronary artery disease as well as cerebrovascular disease. The third chronic complication of note is neuropathy. Remember that polyol pathway. We know that the peripheral nerves do not require glucose for transport. However, this neuropathy has both a metabolic as well as a vascular component. It's characterized by inflammation, ischemia, and those advanced glycation end products. As a result of the changes in the peripheral nerves, there is demyelinization, degeneration, and delayed conduction. So it actually begins with the axons where the Schwann cells are being altered, because that's and their metabolic pathway of the Schwann cell, which is where your myelinization is being altered. In the neuropathy, the distal neurons are especially affected and are especially affected more severely. Persistent hyperglycemia increases both the severity as well as the progression of the neuropathy. So if we pull those pieces together, or a bunch of these pieces together really, both hypo and hyperglycemia have very negative physiologic effects. We talked about the difference in the pathophysiologic etiologies for type 1 versus type 2. And although the etiologies for type 1 and type 2 are different, the end organ damage from diabetes occurs in both, and we want to be sure that we have an understanding of those. Let's end our conversation of the endocrine system with the effects of aging. As we get older, there are a lot of changes in that hypothalamic pituitary axis. If you already listened to the lecture on thyroid and adrenal cortex disease, we talked about the importance of the hypothalamic pituitary axis, and we actually stepped that out in both of those sets of disorders. We also know that as we get older, hormone activity, the levels, the secretion of the hormones, the metabolism of the hormones, and even the excretion of our hormones changes. Some of the significant changes are in the thyroid, the pancreas, in growth hormone, and in cortisol. So in the thyroid, when we look at the gland itself, there tends to be, as we get older and older, some degree of atrophy and fibrosis of the gland. There also is likely to be some inflammatory infiltration of the thyroid gland itself. With that inflammatory infiltration, the gland becomes less responsive to to thyroid stimulating hormone, and there's also less response to the tropic hormone. It is more likely for an elder to present with hypothyroidism than hyper, because of that decrease in the TSH and the response to releasing hormone. In the pancreas, some of our cells can be replaced with fat tissue. Because of the replacement with fat tissue, there is less insulin, fewer insulin receptors, and, as we talked about earlier, an increase in insulin resistance. The incidence of type 2 diabetes goes up as we get older. It's estimated that over 25% of individuals over the age of 65 have type 2 diabetes. When we think about growth hormone and insulin-like growth factor, these are also both decreased in secretion. Now, this leads to a decrease in our muscle mass, our bone mass, as well as our reproductive and our cognitive function. Last but not least, cortisol. We know that cortisol has to be cleared by both our livers as well as our kidneys, and as we get older, that clearance is diminished. As a result of that, then, because we aren't clearing it as much, there is less secretion of the cortisol coming from the adrenal cortex, and that then leads to disrupted circadian rhythms. If you talk to elders, it's not uncommon for you to hear about that sleep disturbance, and that's part of the circadian rhythm disturbance. So we've talked a lot between the first one, the thyroid and the adrenal, and this one that focused on glucose metabolism. It's important that if you're going to understand the endocrine disorders, you have to understand those hormone pathways, and you've got to make sure you understand it's a hypothalamus, pituitary, and then the target gland pathways. Knowing the function and the purpose of the hormone really helps us understand hypo and hyper secretion as well as function, and then we can pick out the manifestation. Hormone imbalances affect all systems and nearly all metabolic functions, so they are important. I appreciate your attention once again, and I'm available for questions. Thanks.